Guys, after subscribing to this channel, please make sure that you also press the bell icon so that no notification, no new video of mine, any educational video, is missed by anybody.
All right. Okay. So we can start the case discussion today on ectopic pregnancy. We have one of our very talented students who's going to help us through this journey of this patient whom she saw in the antenatal ward. And over to you, Kanika, for your case.
Yes, ma'am. My patient, Mrs. X, 24 years, housewife. She is a graduate, wife of Mr. Y, who is 10th pass, businessman from Angul. She attended OPD with complaints of 7 weeks of amenorrhea with mild pain, lower abdomen.
Okay. And history of presenting illness, yes.
She came with amenorrhea of 7 weeks with mild pain, lower abdomen since 3 to 4 days, which is dull aching in nature. It was not severe enough to take any medication, and there was no aggravating or relieving factors. There is no history of bleeding or discharge per vaginum, no history of frequency or burning urination, no history of any nausea, vomiting, or loose motion, no history of fever or rash, and no history of any drug intake or radiation exposure.
Okay, not associated with any bowel and bladder problems?
No, ma'am.
Okay. So just by this look alone, by this presenting illness, and then you took a little bit of history about the pain and all. What do you think is the DD right now, which is coming into your mind, with, concerning which you've taken all this negative history? What is coming in your mind?
Ma'am, maybe it is a case of normal pregnancy, or
Yes.
maybe ectopic pregnancy, or there is any pelvic PID, pelvic inflammatory disease, maybe, or any kind of infection.
Okay. Suppose if I change now, guys, I'm asking all of you in the class. All right, please be alert. Everybody be there and ready in the chat box to answer me this question. Suppose if I change the history a little bit. Okay. Suppose I make this history as acute pain, lower abdomen, along with 7 weeks amenorrhea, and this pain has just started, let's say, 3 to 4 hours back. Associated or not associated with nausea, vomiting? Let's say no, not associated with nausea, vomiting, right? And yeah, severe enough to refer her to you, because she's like maybe late night she's come to you in emergency department with acute pain, which started 3 to 4 hours back. She has taken, let's say, Zerodol or any aceclofenac, diclofenac tablet, but the pain has not reduced substantially. What DD will you think will she have? So everybody who is there in the class, please be alert. Also in the chat box, okay? Be there in the chat room with the help of the pinned message on the main Telegram channel. There is a pinned message from where you've joined the class. There's also another pinned message there. Just enter the chat room and you will be able to discuss this with me. So suppose it's an acute pain. Okay,
Ma'am,
the similar history. Yeah, please tell me.
Ma'am, it can be ectopic, or there is any torsion.
Yes, very good, very good. Excellent. I wanted to hear this word torsion. Suppose it was already a cyst and it has got nothing to do with pregnancy alone. It just got, the torsion of the cyst can happen anytime. It's a hemorrhagic cyst, can happen anytime. Torsion of the cyst can happen anytime. Rupture ectopic will usually, or impending rupture will come to you in such acute pain abdomen. Okay. Anything else? Anything else? Yes, good, Kajal. Appendicitis is what I was looking forward to. Appendicitis pain can start anytime. It's got nothing to do with pregnancy. Red degeneration of fibroid usually takes place in the second trimester, because that's associated with the pregnancy and pregnancy changes. 7 weeks usually does not happen. Yeah. So any acute event can happen at any time. It's just a coincidence that she's also pregnant. Okay, so don't just focus yourself on pregnancy alone. But here we have, thank you guys, thank you so much. I'm very, very impressed. Very fast my students are. This, and you have to be fast in exams, isn't it? Because you can't keep saying in front of the examiner, let me think. You don't have that much time. That's just spoiling your impression on the examiner. You have to be quick. So I appreciate your speed of answering the questions. So yes, right now we are focusing on our patient who's come to us 7 weeks with mild pain, lower abdomen. It could just be a normal pregnancy. Maybe it's an impending abortion. You never know, impending miscarriage. Maybe it is, ectopic pregnancy. Maybe she's just having a, PID along with pregnancy, which is paining her. Okay. If there's anything other than this which is you feeling, let me know. Any DD that is crossing your mind which I have not spoken. Okay. So a little bit about her obstetric history. Right.
Coming to her obstetric history, she is married since 6 years. It's a non-consanguineous marriage. Her obstetric score is Para1 Live 0 with 1 IUD at 36 weeks. Her first pregnancy was in 2008 December. It was a spontaneous conception 3 months after marriage. She had regular antenatal checkup during that pregnancy, taken all medication regularly. She had dengue and typhoid fever at second month of pregnancy, for which she was admitted for 10 days in a local clinic and managed conservatively, but there is no history of platelet transfusion. She developed fetal growth restriction around 7 months of pregnancy, which was a lag of around 4 to 5 weeks, as said by her local gynecologist. In her due ANC in the 36th week, it was found that there was no cardiac activity, and she was admitted in the same day and induced, and she delivered vaginally a male baby who was looking structurally normal but very small in size. Weight was not taken, and no autopsy was done.
Okay, so this looks like probably a sequelae of her infection and pregnancy that happens. Asymmetrical IUD starts developing and then finally can lead to severe fetal growth restriction and then finally stillbirth. But it could also be an improper implantation at that point in time, placental insufficiency leading to fetal growth restriction and then stillbirth. There's a possibility. So there was no autopsy done and there was no other structural abnormality detected. Was the X-ray of the fetus taken?
No, nothing was done, ma'am.
So usually what happens is after stillbirth, these are the options you give to the couple, right? Then you can go in for the, detection of why stillbirth happened. Though it seems like she was having this stillbirth probably because of severe fetal growth restriction, as it is apparent by your history. But maybe there could be other causes as well. So we need to just, at least these are basic protocols that when the baby, is delivered, we examine. Number one, general examination is done by the gynecologist in the labor room, and you can, if there is a doubt, you can call the the pediatrician as well to just cross check. Then you can go send the baby for autopsy. You can at least go in for a complete body X-ray. But as the couple might have or have not consented, looks like they've not consented, so that is why nothing was done in this baby. But here, our current relevant history is not really, it was a normal delivery, right?
Yes, ma'am.
There was no cesarean done. So again, no adhesions and no, relevance in our present history. Okay, what else? Apart from this, okay, this one.
She attended menarche at 12 years. Her cycles were regular, 4 to 5 days flow at interval of 28 to 30 days cycle. There is no history of any dysmenorrhea, passage of clots. LMP was on 23rd July 2024.
Is menstrual history relevant for our case, guys? You can also answer, Kanika. Is the menstrual history relevant for our case?
To know the exact gestational age, ma'am.
And why do I exactly want to know the gestational age specifically in our patient?
If it is,
go.
If it is, if we are suspecting ectopic, then we have to know the gestational age.
Gestational age is anyways important, not just for managing the case, but also to find the DD. So if it's 7 weeks, 6 weeks, 8 weeks, everything especially in the early pregnancy, everything changes, isn't it? There is a point at which you will give the medical management. There is a point after which medical management is not so successful, correct? Then whether to intervene as a surgical, management alone, we need to know the gestational age in the beginning. That is not only to find out the DD, but at the same time for the management as well. So this is relevant anyways, menstrual history, because specifically in early pregnancy, menstrual history is always, always, always very important. No doubt about that. Yes, past history.
Coming to her past history, after her last pregnancy, she was trying to conceive for 2 to 3 years, for which she consulted local gynecologist and advised for diagnostic hysterolaparoscopy. During her DHL was done in April 2023. Found to have right side tubal block with hydrosalpinx with features of tuberculosis, for which right salpingectomy was done. Left tube was pitted on dye test, and hysteroscopy was found to be normal. Post DHL, she was advised ATT, and she completed the course for 6 months. There is no history of diabetes mellitus, hypertension, thyroid, or any other chronic illness.
So this history is again very, very important. And have you noticed, everybody, guys, that she's writing down something like this, April 2023. Even before, she wrote over here 2018 December. This is very important when in exams. Please remember, patient will tell you 5 years back, 4 years back. It's always right to ask the year, or you calculate the year. If she's saying 4 years back, say, okay, fine, that means it's 2018, correct? So, and you write it down. Which month do you remember remotely the month? She'll be able to tell you, obviously, because such a huge incident that has happened in her life, she would remember the year and the month at least. So this is the way to write down. 5 years back could be, in the month of January, February, March, April, or December. The whole year, passes by in 5 years back. So you have to write the month and the year. That is the way to put down the history whenever you're writing down for a past history. So here becomes a very, the case suddenly becomes more serious, because just in case this is an ectopic pregnancy, we already do not have the right tube. So you have to be very, very guarded in this pregnancy, right? So left tube is patent. Okay,
Family
family
no,
history?
no, ma'am.
Okay.
There is yes.
Nothing in personal history?
No, ma'am.
Is there any relevance of personal history over here? Do I want to know anything about personal history?
Maybe if she is smoking is there, or multiple partners.
Yes, that is mostly, you can actually put it down in obstetric history, but you can also put it down here as well, because personal history, you can also say that. If she's got any history of regular recent STDs, she's got a history of multiple sexual partners, whether she's had contracted chlamydia, gonorrhea. Chlamydia is known for causing adhesions. Chlamydia is known for causing salpingitis and further tubal, block and other, tubal anatomy distortion. So you can put in either in personal history, or you can put in an obstetric history. Better to put it in obstetric history. All right. Yes. Anything specific you found in general physical examination?
She is very thin built. Her BMI is 16.9 kg per meter square.
And why is vitals very important for me over here? This is a very, very important part of your general physical examination. Vitals. Yes.
Because it can show if there is tachycardia or hypertension, then we can predict she is.
Yes.
I mean,
she's hemodynamically stable or not. I want to know that. It's very, very important for me to decide, because now I'll be taking you through the Viva, and in Viva I'll be putting all different case scenarios in front of you, so that I'm trying to judge you what will be your clinical acumen into deciding whether this patient can be managed expectantly, or she needs a medical management. She'll be fine with medical management alone, or you will take her seriously and offer her a surgical management. Patients most of the time they ask, doctor, what do you suggest for us? What is your gut feeling? So your gut feeling will be based on all these factors. You will remember that her left tube is patent and right tube is gone. She's got a right salpingectomy done. You will know that she's hemodynamically stable. You will also know that she's just having mild pain, correct? And what is her beta HCG level? And then we'll decide accordingly, right? So yes, vitals are very important, because we need to know whether she's hemodynamically stable or unstable. Sometimes patients have a very vague perception of pain. Some people who are absolutely normal will shout in pain, and some people who are going in hemodynamic disorder will, just, lie down as if nothing is happening to them. They'll not be breathing in pain. Probably the pain is gone, or they have a very huge capacity of tolerating pain, and they will not complain. So you have to judge it on the basis of these signs rather than symptoms. And this happens to be a very important part of, just in case you're going towards ectopic pregnancy. Pallor is very important again. Yes.
She had mild pallor, no icterus, cyanosis, clubbing, or lymphadenopathy. Her breast and thyroid appears normal. Systemic examination, respiratory, CVS, and CNS also appears normal.
So right now everything seems okay. She's just got a mild pallor. Okay. Now, what about inspection and most important palpation? Yes.
On inspection, all quadrants are moving with respiration. Umbilicus central and inverted. Striae marks of previous pregnancy was seen. Scar of previous laparoscopy was seen and healthy. Hernial orifices are intact. On palpation per abdomen, it is soft. Mild tenderness on lower abdomen. No guarding rigidity. No organomegaly. No distension. On auscultation,
do you have any specific place at which her mild tenderness was more pronounced, in the lower abdomen, left side, right side, central?
Little bit more towards the left side, ma'am, but it was not very significant.
Already has salpingectomy, and if it is ectopic, she'll have more tenderness towards the left side. But where is the per vaginal examination with her?
Next step.
Okay, I'm sorry. You're done with auscultation?
Yes, ma'am.
Bowel sounds are present. Okay.
On local examination, her external genitalia looking normal, pars speculum, cervix, vagina looking normal. There was no bleeding or discharge seen. Bimanual examination, uterus anteverted, bulky, cervix posterior, mild tenderness on left adnexa.
Okay. Yes. So summarize your case.
To summarize my case, Mrs. X, 24 years, graduate housewife, with previous history of stillbirth at 36 weeks, delivered vaginally 3 years back, followed by history of right hydrosalpinx, undergone right salpingectomy, taken 6 months ATT, and came to OPD with 7 weeks amenorrhea with mild pain lower abdomen for 3 to 4 days without any bleeding or discharge PV.
Okay, very well summarized. So now all of us know in one, look, what is our case. She's taken his, treatment for ATT. She already had salpingectomy, right salpingectomy. There was one delivery which actually had a stillbirth, and that was a normal vaginal delivery at 36 weeks of gestation. Obviously, it's got nothing to do with the condition right now, but we know that she's got a bad obstetric history to say with. She doesn't even have one live child, and now a lot depends upon this one tube alone to decide for her obstetric future, correct? So we have to take decisions based on all these factors. So the most important thing for any examiner is to look at your summary, and your summary has to be just right, just discrete to tell us the points, that what are exactly the points to be remembered when we are dealing with this patient. Okay.